I don't normally say yes to doing keynotes, but health equity and the fight for Black health is for me part of my story. And the real truth is, I was on holidays on a cruise, and I got an email that said, "Oh, Camille, will you do this?" And in that moment, I said, because it came from Sophie and Gideon, I said, yes. And then I came home and thought, what did I do? I say that because timing is sometimes important. When I first came to Canada in the 1960s, there was not sufficient funding for health care for Black people, and there were very few organizations by Black people for Black people delivering services for Black people. As we, the Black people, built these programs, we built them from the ground up. We built some amazing programs. We were responding to huge need in the community, and we came together in ways that had big impact on our communities. That great legacy is present here in the room today. We have organizations like Taboo, Queen West, Women's Health in Women's Hands, Black Health Alliance Partnership Project, Pathway to Care. I want to acknowledge all the great organizations and organizing that have gone on in the past to have gotten us the care we need. So we have accomplished a lot, and we have made Black health a part of the conversations. There are very little conversations, few conversations in the community health space that does not include voices of Black people fighting for and demanding better care. And we put critical supports in place for the people who are the most vulnerable in our community. These programs have also proven to be incredibly resilient to changes in governments and to changing in funding over time. And we know community organizations have certainly been squeezed where funding is concerned, and Black organizations in particular. They have made funding go a long way, and a lot of it is by partnering. We've also done a great job in adapting to change as the Black community has changed. I want to just take a minute, because I think it's important. There's always been Black people in Canada, always. So there's Black people in Nova Scotia, in Alberta, in Chatham, and here in Toronto. So that's important because when I came to Canada in the 60s, most of the Black immigrants then were from the Caribbean. But now we see Black immigrants from Africa, from South America, and that's outpacing the Caribbean migration. And that diversity brings us unbelievable richness in the Black community. Another population I just wanted to identify is the Indigenous community. A large percentage of the children in Indigenous populations are Black. And we often, when we talk about Black, we don't necessarily always include those kids, and I think it's important. When each of us are in spaces talking about Black health, we need to remember, if we're Caribbean, we're not only talking about Caribbean. If we're African, we're not only talking about African. We need to still talk about the Black community, but we need to remember the diversity with which we're talking about and representing. And not make the system have one of us in a room and then say we have the Black experience because so-and-so is in the room. We do not have the resources to support our communities. And we need to acknowledge that. And we need to continue to recognize that. What that does is a large portion of our population, then by choice or by need, get their primary care and community care from mainstream, or they go without. But our health needs and our healthcare needs go beyond primary care. So I'll just come back to that. So what we really need to do now is, having done the community side, done a lot of work, I think we need to just change gears and begin to talk about accountability. We need a system that is accountable to meet all our needs. Since all of us are not getting our care from Black organizations, we go to mainstream for primary care, so we need to begin to talk about accountability. We need Black health to permeate in every part of healthcare, not just community programs, but also cancer care, cardiac care, acute care, retirement homes, mental health and addictions, public health, and research. Clinical research, social research, but we need our presence in research. The programs that many of us in this room have built and nurtured have been essential to the community. We have a lot to celebrate, but we're not done. As I previously stated, the majority of Black people get their care by necessity or by choice from mainstream healthcare. We need to hold mainstream healthcare accountable for the access to their services, for our experience when we go to those services, and for the outcomes we have. Now, I speak to you today from a unique vantage point. I've had the fortune to work in roles that gave me a bird's eye view of the health system. I know the inner workings of government and of the LIN and of the machine that is healthcare service delivery in this program. I also speak to you today from another vantage point. I am retired. I am no longer tied to the health system. I have the luxury of being able to call it like it is without worrying about losing my job or feeding my kids. And what I see is Black health being kept at the margins of the current system. I see us not being able yet to call out, we talk about data, but I think we need to really also say the lack of collection of data is also a racist event. And we need to be able to say that, and some of you in the system may not be able to say it. Those of us who are out of the system need to be able to call that what it is. And I will say, for example, Hospital for Sick Children. If you look at the population in Toronto, the diversity of the population in Toronto, and that's mostly children, right? Seniors, we have a different set of population. Children, dominantly kids of color, etc. Hospital for Sick Children do not collect race-based data. So we've got to say, how are you doing research? How are you doing medication research? Because we know the difference in medication based on genetics, based on race, based on color, based on society. If they don't have that, how are they treating our children? So, just call that out as just one example of where we need to really begin to look at organizations and say, what's really going on here? What has happened over the years as the Black community has advocated for funding is that government has responded by giving a small amount of funding. This pittance in funding is designed to silence us. What happens then when they silence us? They can turn around when you go into rooms and you begin to argue. They say, "We got Kaibu." And we said, yes, but all Black people don't live in Kaibu catchment area. What about Black people who live elsewhere? So we get these pittances from these programs, which are all good programs. But we've got to recognize that that is about silencing us. It is not about getting us population health outcomes. Like mental health, there are a number of programs in the Black community, but they're really not funded adequately, even when for the population they serve. Then we have agencies like, say, again, calling out, say, CAMH, get a significant amount of funding for mental health. How much of that funding is geared to programs that's specific to the Black community? Those are the kind of questions we need to be asking of all of these organizations. Give you another example. Cancer Care Ontario years ago did pap smear. We have these tests coming in, pap smear, colonoscopy, all those things. So they did a great job in screening. They did a really good job. They got about 85% compliance. So I was sitting on an advisory committee, and we were thrilled about that. And then I said, well, who's in the 15%? Well, 85 is a good mark. And I said, yes, but who's in the 15%? So when they went and looked at the 15%, it was Muslim women, newcomers, women of color. And so we said, is that okay? To give Cancer Care credit, they then created some program targeting those communities. That was an afterthought. So when we're talking about accountability, we need that thought to be in the forefront of the planning. Mainstream organizations need to be held accountable. Every organization that is funded to provide health care should be accountable for equitable access to those services, the experience we have when receiving those services, and the outcome. I want to be really clear about what I mean. I'm not only pointing fingers, because I am. But we need to begin to talk about these systemic issues and and understand why health equity has been so hard to achieve. Because it's an uphill battle and we're fighting against the establishment. Look at the funding. Most of all the Black health programs we are talking about are funded through community dollars from government. To put this in perspective, the total healthcare budget in Ontario is about $59 billion. Now in Toronto, the Toronto Central LHIN budget is about $5 billion. Less than 500 million goes to all community programs put together. That's a rounding error. Another way of looking at it. A rounding error goes to community programs, and in that community programs, very, very minuscule part of that goes to the Black or Indigenous communities. And so then we wonder, why are our outcomes that much poorer? Accountability also plays out as who sits at the decision-making tables. Maybe I'm wrong, but I don't believe there's a single Black CEO of a hospital in the world that as I started looking around, I couldn't see any. I don't know if there's a Black APM in the Ministry of Health. Now, the cynic in me now pull up the board of the New Ontario Health, I pull up the healthcare teams, I begin to look at all the hospitals, all the providers, and I begin to look at who their senior teams are, and I begin to look at who's right below the senior team, and there ain't too many of us in any of those places. And the horrible thing is we're not even in the pipeline. So that for me is problematic. Until we have Black leaders as policymakers, researchers, service designers, until we are represented at all those tables, our work here is not done. Our fight used to be about dedicating dollars for Black health programming, about community services. We have achieved some success there, but Black health or the health of any marginalized group do not exist only in the realm of community services. And I want to be really clear that I'm very happy. We should all be proud about community services. This is not about community services. This is about how we need to now change focus and add some other dimensions other than only looking for dollars for community services. Because they'll throw us bones each time around that. The truth is we have not yet seen much improvement in access, experience, or outcomes as far as our Black health is concerned. So, for example, a colleague raised with me recently that the Black community represents 9% of the total population, but the shelter system, 30% of the people in the shelter system are Black. Is that a direct correlation with the lack of access to mental health care? Is that the long wait that it takes for us to get access and get care? In the meantime, as our previous I was about to say patient, identified for us, a lot of things happen in those long waits and not getting good access to care. And so that is really, really important. We will not have real impact on the overall health or experience of Black people unless we start holding leaders in healthcare and government in healthcare and public health and research accountable, and we have to be at those tables. Health services can no longer be blind to differences in outcomes and access to Black people, or any other population. It just doesn't make sense. It doesn't make sense from a human cost point of view, and it doesn't make sense from a system point of view. I think those of you that will be in one of the sessions later will find out. For example, we hear today on the radios, hearing all about ALC. Somebody in Barrie saying, I have to wait 3 days because of ALC. Very few to work, and I've sat on ALC tables for years, wasted a lot of years. But nobody there looked at who are these people. And there's a disproportionate number of Black and Asians in those ALC beds. And it's not because they really like hospitals. So, until the system start to really do that kind of work, who are these people? Why are they there? What led them there? Why can't they leave? We're not going to solve the ALC problem. So we see money being thrown at it, we see news about it, but no, the real root cause is still not being looked at. People in decision-making positions, they really plan the healthcare around their own experiences. It is about what they know, what they value, and how things work for them. We know that doesn't really then apply to us. I'll give you another example. I sat on a table looking at long-term care design. And there were standards being introduced about the size of the rooms, this, to this, to this. And I said, but that's all a white middle class set of expectations. I live in a condo, and my condo is smaller than what you're saying. And I pay a lot of money for that condo. So your sense of size and stuff just doesn't make sense. Shouldn't we be looking at nursing homes that have more community rooms, common rooms, these kind of stuff so people can share? And why are we having exceptions to this so that certain builders, especially in Toronto where the land is so expensive, can come up with another design? No, we still have one standard for long-term care across the entire province, which makes no sense in the downtown core. I have a vested interest in that table because I've always lived in the downtown Toronto, and I don't want, as I get old and need nursing home, to have to leave Toronto. And that really is what is ahead of us as we're having fewer and fewer beds in the city core. We did see some progress being made, like Health Care Ontario had a whole unit dealing with equity and equity lens. They started to change their reporting. So rather than only put out aggregate data, they then was starting to pull out sub-data to show from an equity lens. So they started showing if you lived in these areas as a woman, you were more likely to have cesarean section than if you lived here. If you were this population, you were having less access. Well, I have no idea what's going to happen to Health Care Ontario and this work under this present system. I think we need to be calling out for that and need to be calling on Ontario Health and the Health Quality Ontario portion of that to continue that work. I'm afraid it may get lost as we go forward. As we head into today for a conversation about Black health, I want you to think about three important relationships that we need to now focus on: data, accountability, and leadership. I first want to talk about the power of data. You have already heard several people talk about that. So, what is the outcome for individuals? How do they access, how do they experience healthcare? Is it the same as their white counterpart? Why not? These are questions we need to be able to answer, whether we're talking about COPD, mental health, or long-term care. These are questions that every health leader in this province should be able to answer, and every board of directors. But the reality is that we mostly don't collect this data. We aggregate healthcare in a way that obscures what's going on. Do Black women, or Indigenous women, or South Asian women with breast cancer have the same survival rate as white women? In the US and the UK, they know that. They can tell you that down to the hospital level. We do not know that in Ontario, we do not know that in Canada. What we do know is that in all probability, our survival rate is less, shorter, because we're not getting the test right, we're not getting the referral at the right time, and we're not having access into the specialist thing. So in Canada, we do not traditionally collect race-based data. So we have to rely on literature or small studies. None of that really work for us. We need to then begin to focus on the outcomes for Black and Indigenous people. We hear about the Ontario Health teams. My question about the Ontario Health team is they're asked to look at populations, but nowhere are they asked to look at the population in the geography they're at. They're asked to talk about population of who is on their roster. And those are two different things. And we need to be talking about those of us who are not on the roster. Who's taking care of our health? How does that happen? Etc. That's a key point. We need to insist, advocate, and demand that the system collects data on racialized population. And then the other thing is we need to now focus on the population level. So as we do the work, Black Health Alliance, Wellesley, all of these organizations, do we step out of the program space and into the population health space? Do we then focus our work in that arena because there's no one else doing it at that point? We need the system, as I said before, who is directly accountable and accountable back to the communities. The number of Black people in position of power do not reflect the city. And it really does not reflect our ability, our talent, or our experience. We see all these students, we see all these professionals, we see all these young people, and we know you all hit the glass ceiling very early, and you do not get into decision-making positions. We need to talk about how do we gather that data, how do we put that out? Maytree used to do some of that work. Do we then partner back with Maytree and says, we need this information? So leadership and accountability go hand in hand. And I'm here to say, unless we're at the decision-making tables, we're going to be on the sideline. We're going to be afterthought, and we need to stop that. So how do we strengthen our call for action? There are two things that I think, as you think through the day, that you should think about. Look at alliances and partnerships. They can be good, they can be annoying, they can be frustrating, they can be all of that. But if we keep focusing only at the service level, the system has kept us racialized people, marginalized, on the sidelines. We get funded in all the different streams. We get funding for refugees, we get funding for LGBTQ, and in some ways that keeps us divided. That doesn't mean our leadership in all of those programs can't come together. So I think there are two parts of coming together we should think about as we go into the afternoon. The first one is, if we're talking about Black health of our people and us, then we need the healthcare system leaders to come together with the legal system leaders, to come together with the housing leaders, all these fragmented pieces, because it's a collection of all of that that lead to our improved health. So we need to even challenge our own leaders to say, you need to do your work in your stream, but you need to be doing your work collectively for the population. Within healthcare itself, we need to also form another kind of grouping where we look at who else is in the healthcare space that's not getting good care, and instead of each of us going to government individually looking for something, we need to begin to put that together. So we have the indigenous community, we have the Black community, we have the Asian community, and each of those communities are going saying, I need this, I need this, I need this. I've been at the tables, it's a perfect excuse for government to do nothing. It really, really is. Because they say they don't want the noise, they don't react, and then they say, well, if we give you, you're going to be upset, so we're not doing anything. And that's what has happened all along. So there are places where now we need to work together collectively to do that. And give you a concrete example of how I think that has worked in Canada. In the early 80s, 90s, when AIDS came on the scene, there was an advisory committee to the Minister of Health at the time. I was on that committee. Drugs, the cost of drugs, the cocktails were just coming up as exorbitant. And so the committee decided that we should recommend to the minister that the minister offset the cost of these drugs. And I said, no, I could not support that. It did not make any sense to me. If I was the minister, I wouldn't do it. Of course, then the committee got upset with me. I said, no, you need to hear me. What we need to do now is to go across to other disease entities whose people are having high-cost drugs, and then see if we can come together. I can tell you back then, it was a hard slog. Homophobia was rampant, heart disease, diabetes, all of those wanted nothing to do with AIDS and the people doing work with AIDS, but we stuck it out. We went into rooms and we were treated badly, etc. But we prevailed. And at the end of that, we collectively put in a request for the coverage of catastrophic illnesses. Now, it's not perfect, but it was the best we could do at the time, and that became Trillium, which, by the way, needs to be renewed. But at the time, but that's an example of having one clear goal that we could partner with people who normally wouldn't partner with us. We had to go through the homophobia. We will have to go through some racism, trying to form some of those partnerships. But it may be of value to us to get some of that work done. So around Ontario Health, I think that's an opportunity. I think Ontario's Health, we need to hold them accountable, that they hold providers accountable to deliver, improve access, or experience and our outcome. And so whatever else we do at the end of the day, I hope that we can get there as one place. We need to then get back to the Ontario Health Quality Ontario, who's now under Ontario Health, and so that they can continue the work they were doing. We need to look at organizations who are already in our spaces to see whether or not they will pick up some of the work that we come up with today. We often will say, we don't get a new organization, or we don't get funding from government, we can't move. And I'm thinking we can rethink some of that. We do have some Black organizations or organizations specializing in equity work that could probably help us to do some of the work that we need to do going forward. In closing, I think we have a lot of leaders in the room. You can accomplish a lot. I would say to you, particularly young people, pick your battles. And I would say to you that what my mom would say to me, pick your battle, but hold your course. And as a child, I had no idea what that meant. You know how we used to get these sayings? But I understand if you have a goal, you're going to the goal, you can't fight every battle, but you pick the ones that advance your goal. I want to say to you that I have stood on the shoulders of the leaders that came before me, and it is from their shoulders that I offer you mine. We need to add, amplify, translate, but we also need to celebrate. So hang around for the wine and cheese. Oh, she didn't say wine, did she? I don't know, Sophie, I don't know. But hang around later and meet each other. The key here is networking. You need to know each other. You need to have people you can call, whereas you do this work. Things will get hard, it will get tough. I have a few friends in the room. I had a good friend, Joan, that died, and things would happen at work, and I would pick up the phone and I would say, can you believe this? Can you believe this? Swear, 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 swear. And she would say, yes, girl, I know, I understand. And then I could put down the phone, breathe a sigh of relief.